Good afternoon, everyone, and welcome to the first California Black Health Network's Health Equity Forum of 2022. I'm Rhonda Smith, the Executive Director of the California Black Health Network, and we thank you all for participating in today's Health Equity Forum. Our session today is Cover California and the Black community, and it's an opportunity to engage in dialogue with leadership at Cover California and provide feedback about ways in which Cover California can better serve the Black community. So I'm excited to have our guest today, Dr. Alice Chen, who's the Chief Medical Officer at Cover California. Now, California Black Health Network and Cover California have had a long-standing relationship. We've been an enrollment navigator for a number of years, and we're very fortunate to have the opportunity to have a dialogue with Dr. Chen today and learn more about what is up and what's happening at Cover California, their health equity initiative, as well as some other initiatives and future plans that are in play. But before we start, I just want to cover a few housekeeping rules. First, we will hear from Dr. Chen, and she will share a little bit more about what's going on at Cover California, and then we'll engage in a conversation to do a deeper dive and learn more. You'll have an opportunity to ask questions and provide feedback to Dr. Chen on what Cover California can do to better serve the Black community. And then we'll have the chat box enabled. So if you want to connect with others that you see on the webinar today, or provide comments along the way, you're happy to do that, or we're happy to have you do that. But please specifically pose whatever questions you have for Dr. Chen or feedback in the Q&A box. And last, everyone will remain muted until the end of the session. So again, you can communicate through the chat box or the Q&A box. But before I introduce Dr. Chen, I just wanted to take a few minutes to share a little bit about the California Black Health Network in case some of you on the call today or on the webinar today are not familiar with us. So we were founded in 1978 as a membership and affiliate network. We had our first statewide conference in 1980 and expanded to 6 chapters and affiliates across the state. And then in 1983, CBHN officially became a nonprofit organization in 501c3 status. We were very instrumental in starting the Office of Multicultural Health. And those of you may be more familiar with the California Pan-Ethnic Health Work, or otherwise known as CPEN. So we are a co-founder and a partner with CPEN as well. Our overall vision for CBHN is to create a California where every African-American and Black immigrant has the opportunity to live a long, healthy life free from violence, racism, and health inequities. And we carry out our mission every day to work towards achieving that vision so that we ensure that all Black Californians, regardless of their education, social, economic background, where they live, who they love, who they identify as, and their housing status, has the opportunity to access high quality and equitable primary and behavioral health care and avoid unnecessarily succumbing to diseases that unfortunately people die from unnecessarily so. And so I'd like to move into our program today and introduce Dr. Alice Chen, the Chief Medical Officer at Cover California. Dr. Chen, in this role, is responsible for healthcare strategy focused on quality, equity, and delivery system transformation with the goal of improving access and outcomes for all Californians. Prior to joining Cover California, Dr. Chen served as the Deputy Director for Policy and Planning and the Chief of Clinical Affairs for the California Health and Human Services Agency. She led many of the agency's signature health policy initiatives on affordability and access, and played a key leadership role in the state's response to the COVID-19 pandemic, which is actually how Dr. Chen and I got connected, doing some work around COVID equity across the state. She's also had experience in the areas of strategic reopening relative to COVID, hospital surge planning, equity, data analytics, and also therapeutics. She has a long history of leadership in enhancing access and quality of care for vulnerable communities across the state and mainly in the Bay Area, but also working with communities through patient care, teaching, policy and advocacy, delivery system innovation and administration, and leadership across a variety of settings, including community health, philanthropy, and academia. For about 15 years prior to her role with the agency, Dr. Chen was a professor of medicine at the University of California, San Francisco School of Medicine, based at the Zuckerberg San Francisco General Hospital, where she served as the Chief Integration Officer and founding director of the eConsult program. There's a lot more that I could say about Dr. Chen's work and her experience and the impact that she's had on communities that she's served, but I will let her do the honor of sharing a little bit more about her background and also what is happening at Cover California. So without further ado, I'd like to welcome Dr. Chen. Thank you again for spending some time with us today and for the opportunity to have a dialogue with you and learn more about what's happening at Cover California, but also provide some feedback from the community.
Yeah.
So I'll turn it over to you.
Rhonda. Excellent. Yes. It is such a delight for me to be with you and with California Black Health Network. I was actually on the board of CPEN many years ago when Calvin Freeman, I think, was acting director, and have great respect for the work you do. Actually, I knew more about CBHN in terms of improving the health of African Americans in California, working on disparities and equity, and only after coming to Covered California realized that you were one of our key navigator partners as well. So it's really nice to connect on that front also. Let me just say, I want to start off, and let me just also say that I hate virtual forums, and I hate virtual community forums even more than usual forums, because the whole point of a community forum is a back and forth discussion, questions. And so normally if we were together, I would kind of throw it out to get a sense of what do people know about Covered California. So in the absence of that interactivity, I will ask you all to bear with me, and I'm just going to do a little bit of background on Covered California, recognizing that some of you may be really familiar and some other people may be at that level where, oh, I think I've seen that mask before, but have no idea what we actually do. So let me just say a little bit. So let me back up to 2010 briefly and say that Covered California is an integral part of the Affordable Care Act, or Obamacare, or the ACA, as it's variously known. There are three really critical, there are many, many parts of the ACA. It was a 1,000-page bill, but I would say three things with regards to coverage. One is expansion of Medicaid. We were one of the first states to embrace ACA, expand Medicaid, establish a state-based exchange, which is Covered California, and also lean into the federal reforms about making health insurance rules more fair for consumers. So eliminating things like pre-existing conditions, lifetime limits, all that really arcane stuff that was in the fine print of your health insurance policy that people didn't really understand until it got hit with a denial letter. So what I would say is we have done a phenomenal job here in California. Our uninsured rate has decreased by more than any other state, from 17% to now 6%. Much of that is in our communities of color. For African Americans, the uninsurance rate has decreased by 2/3, and we still have a lot of work to do. We still know that there are persistent and significant disparities in not only healthcare coverage, but obviously access to care, and then health outcomes for many of our communities, in particular African American communities. So we can talk about that a little bit later. Let me just say, right now, Covered California has 12 health insurance companies as part of its marketplace. So I suspect you've heard of them all: Kaiser, Blue Shield, Anthem, HealthNet, LA Care are but a few of them. Depending on what part of California you live in, you have access to different ones of these carriers. Importantly, Covered California is the only place a consumer can go to get financial assistance, to pay for their premiums, to buy this health insurance. So in terms of who should be thinking about this, and if you know anyone who is uninsured right now and who is not eligible to get insurance through Medi-Cal, Medicare, or their employer, and there are certain provisions, fine print provisions in the employer side about whether it's affordable and some parameters, you should come to coveredca.com and check out what you might be eligible for. Californians who are low to middle income could be eligible for really significant financial help. Last year in 2021, about more than half of our enrollees paid less than $10 a month for health insurance through those carriers that I talked about before, the Kaisers, the Health Nets, the Anthems, less than $10 a month. Those with incomes in the higher range, and when I mean higher range, I mean for a family of four, around $100,000, are still eligible for financial help. Not at the same extent as for lower income people, but the main message is don't leave money on the table. If you don't have insurance, if you're not eligible for these other areas, before the end of this month, because open enrollment ends on January 31st, please go to Covered California, coveredca.com. I'm just going to check and make sure there's a couple other things about our enrollment. No, so let me pivot for 1 second and just talk a little bit about what we've done in addition to enrollment, because our main function is to make sure that people who are eligible for these financial assistance get connected to the financial assistant, connected to their coverage, get connected to care. We also have leaned in pretty heavily in terms of health plan accountability. And I'll stay at the high level, but at this point, most people in the United States get their healthcare coverage through a health plan, through a health insurance company. And what we've been doing is in California, working with Medi-Cal on the one hand and CalPERS on the other. Medi-Cal now covers about 13 to 14 million Californians. Together with CalPERS, the three of us cover about 42% of Californians, and we're leaning in heavily into things that we think will make a difference in terms of improving the health of our diverse communities in California. And that means disparities reduction, it means behavioral health, it means access to effective primary care and integrated care. It means making sure that that care is affordable. And before I pause, I just want to say one key component that I just want to put out there is the issue of data, because what we've realized is that in order to understand how we're doing in terms of disparities, in order to be able to hold our health plans accountable, we need to be able to stratify our health outcomes data by race, ethnicity, and language at the very minimum. You know, we're also looking at SOGI, we're also looking at income, we're looking at geography, but where we're starting is race, ethnicity, and language. And I'll say that that data is not complete right now. Our own enrollment data has about 20% of enrollees who have not completed those fields. And so one of my key asks to California Black Health Network and your partners is help us communicate to the community why it's important to collect race, ethnicity, and language data. Because, you know, Rhonda and I were talking a little bit earlier, change happens at the speed of trust. Knowing what people are going to be doing with that data is important. And the reason we're collecting it, the reason Medi-Cal is collecting it, the reason CalPERS is collecting it is to see, are there disparities? Or we know there are disparities, but how big are the disparities in diabetes control, in blood pressure control, in infant mortality, in maternal outcomes? And then by knowing how large and where they are, we can then focus our efforts in a concerted way to really try to move the dial. Rhonda, I think I'll pause there just because I'm sure there's a lot more to talk about and I don't want to just keep going on.
Yes, thank you, Dr. Chen. So I think where I would like to start is something that you said, like change happens at the speed of trust or something along those lines. And so I want to talk about that in the context of the data, right? Because I think sometimes when we're asked to provide data, we may not know why people or organizations or whoever is asking for that data and what they're going to do with that data. And you touched upon that a little bit, but could you go a little bit deeper and talk about, you know, the importance of collecting that data and then what can you do with the data to really begin to address disparities, like you mentioned?
Yeah, absolutely. So, I mean, I'll go on a slight tangent first, which is that, one of the things that Covered California has been doing has been advocating at the federal level at CMS to adopt a more intuitive race ethnicity framework than is currently being used. Because I don't know how many of you are familiar with the nitty gritty of, separating ethnicity and then race and then national origin, and all gets mixed up. Here in California, we are such a diverse set of communities. We need a more intuitive framework, because I do think that part of the reason we don't get complete data is because it's confusing. People look at this, these check boxes, they're not sure what to check, and a lot of people just check other, or they're like, I can't figure this out. To give you an example of what we do with our data, so for example, we have a big initiative that is working its way through the board as a proposal called the Quality Transformation Initiative. And what we realized was in healthcare, because we collectively take up 18% of GDP, we will be measured on many, many, many things, and that is right. It is very difficult for any organization, healthcare organization, community-based organization, service organization, to improve on more than a few things at a time. So we decided to look at what are the key drivers of morbidity and mortality here in California. And it's the same as everywhere in the United States. It's cardiovascular disease and it's cancer. And so we have chosen 4 measures: blood pressure control, diabetes control, colorectal cancer screening, and childhood immunizations. And we are proposing to tie significant financial consequences to health plan performance on these over the course of the next contract cycle. We are also going to be stratifying them by race ethnicity and looking at, for every health plan, where are your racial and ethnic disparities? Where are the groups that are performing the poorest? And how are you going to intervene? Now, we don't have a national methodology and benchmarks to be able to tie financial consequences right now. But what we're signaling is this is so important that you need to be able to collect the data on your enrollees, stratify your outcomes data by race ethnicity, so that you can start looking and working on it. And within the next couple of years, we're working with Medi-Cal, with CalPERS, with actually organizations at the state and federal level to try to determine a standard methodology, because we're planning to also tie financial consequences to disparities reduction. Without that data, we wouldn't be able to do that. So that's, I hope, like a very specific example in terms of diabetes control, blood pressure control, colorectal cancer screening, childhood immunizations, looking deeply into seeing which communities need the most support and engagement and outreach.
Right. So you're talking about, in a sense, having some sort of maybe health equity metrics that are similar to Hedis scores for like community healthcare centers, but more across the board for health insurance plans. Is that kind of what I'm hearing you say?
Well, exactly. And actually, we've done that already in our current contract. We have certain Hedis scores around diabetes and blood pressure that the health plans can choose one and then identify a disparity to work on. And all of them have chosen either African-American or Latino control of blood pressure or diabetes. We're then rolling that into these 4 measures and requiring all 4 of these Hedis measures, as you mentioned, they're all Hedis measures, to be stratified and to be focus areas for disparities going forward.
Great. So for those people who may not know exactly what Hedis measures are, can you provide an explanation or more detail what they are and why they're important? Yeah.
I can't off the top of my head tell you what the acronym stands for. I think it's health, evidence, something, but the Hedis measures are a set of validated, vetted measures that health plans are held accountable for. So all health plans that have what's called NCQA accreditation, National Committee on Quality Assurance, is one of the key accreditation bodies for health plans. as a part of accreditation, they actually have to collect and report on these Hedis measures, and they're pretty comprehensive. The conditions I talked about before, but also asthma care and cervical, all sorts of cancer screenings, different measures for different chronic conditions like heart disease or rheumatologic diseases, also utilization measures, also behavioral health measures. So there's a whole host. I don't remember exactly how many Hedis there are, but again, of those, we've landed on 4 to really focus our efforts on.
Great. So it's great to know that that health insurance plans are being held accountable for outcomes. So not just providing the proper, quality healthcare or accessibility, but also performance around outcomes. I think we probably don't think about that, or most of us may not be aware of that fact. So we're in the midst of open enrollment, as you mentioned earlier. Open enrollment closes or ends at the end of this month. How are things going this year versus last year, especially because of the American Rescue Plan? Have you seen any differences in, I guess, uptake and enrollment?
Yeah, we have. I'm gonna plant a seed and ask people to join us at our media event tomorrow. That you'll be one of our key highlighted guest speakers at. But I will say we have been really pleased at the uptake. We have been pleased, particularly with the impact on communities of color. African Americans, Latinx, Asian American communities are definitely our intentional focus on diverse agents, diverse media outlets has paid off. And again, there are still disparities. Even with significant decreases in uninsurance among African Americans, and I will give you a little teaser. Between 2013 and now, it's dropped by about 2/3. Still, African Americans are 1.5 times more likely to be uninsured than whites. So again, and it's not just about Covered California, it's about Medi-Cal. It's about Covered California. It's about making sure that people know what all their options are, and that we make it as easy as possible and as frictionless as possible to get the care you need, to get the financial assistance you need.
Okay, so
go ahead.
Sorry, go ahead. No, go ahead. Sorry.
I was going to say one more thing, which is we estimate there's still 1 million Californians out there who would be eligible for low or no cost coverage, either through Covered California or Medi-Cal. So there's still 1 million people out there who, within the next 2 weeks, if they go to coveredca.com, can find out, because we work hand in hand with Medi-Cal to have no wrong door. So if you go to that one site, you can figure out if you're eligible for either.
Okay. And do you have a sense of the demographic breakdown of that 1 million uninsured California residents?
That is really challenging. Our policy team is working on that.
Okay.
Partly because we have to triangulate through American Community Survey, through California Health Interview Survey. Some of that has been stymied by COVID in terms of the surveying. But that's the exact same question we have, is who are the remaining uninsured, so that we know who the right partners are to reach them.
Great. And so we know that, we have health insurance that helps us when we get sick or we go see the doctor. But can you talk a bit more about like preventative services that are available? Because you mentioned or alluded to this earlier, like a huge part of our healthcare costs in this country are related to chronic diseases, which are mostly preventable. So I think it's important to really focus more on what we can do that's in our power and control to, engage in to prevent certain diseases and health conditions from happening. So can you talk a little bit about those services that are available through your qualified healthcare plans?
So I really appreciate your highlighting that, Rhonda, because I think from my experience, and full disclosure, I'm still a practicing physician at Zuckerberg San Francisco General. Health insurance is confusing. And so I think people purchase healthcare insurance sometimes for 2 different reasons. One is catastrophic coverage, right? To give yourself peace of mind, knowing that if you get hit by a car or if you break your leg, that you won't both be dealing with your health issues and financial issues. We know that healthcare costs are a leading cause of personal bankruptcy. So that's one component of it. The other piece is health insurance gives you access to needed care. And so what I think is really important for everyone on this call to understand and to spread the word is the Affordable Care Act, the ACA Obamacare, basically made certain preventive services free. No matter what your deductible or your copay is, the cancer screenings, immunizations, screenings for high blood pressure, diabetes, high cholesterol are at no cost share to the enrollee.
Okay.
In addition, Covered California has really tried to create what we call standard benefit designs that promotes primary and preventive care. So except for folks in bronze plans who still have the ability to go to the primary care doctor 3 times with zero cost share without any component of the deductible, for people who are silver level and above, and I apologize because I know these terms are a little bit technical, silver, bronze, but at most levels of care for most of our enrollees, the only thing that's subject to a deductible, significant deductible, is hospital care. And we know that only about 3% of our enrollees get hospitalized in a given year. So we really try to incentivize by not having the deductible apply to things like primary care visits, lab tests, x-rays, specialty visits, urgent care, so that people don't have that question in the back of their head, can I afford this even though I'm paying for insurance?
Okay, great. So I want to go back to data for just a minute. And so I'm curious about whether or not you have any data on who utilizes preventative services in the qualified healthcare plan. So you have a sense of what the demographic distribution might be for that?
We haven't looked by race, ethnicity at the utilization of services yet. We've been more focused on outcomes. What I will say is I just came across a brief looking at the impact of ACA writ large nationally, and there have been actually significant reductions in disparities for African Americans and Latinx communities in particular as a result of the ACA promoting no cost share for preventive care. Okay. So at least in the nationwide, we know that there are actual increased uptake for underserved populations. Okay.
So most likely that translates into the same thing here in California. Yeah, because So I was going to ask, what do you think are is the link between access to healthcare coverage and the impact on health disparities, but you kind of already answered that. So I think the important takeaway there is, we do have the option to, especially if we have health insurance coverage, I think either through the qualified healthcare plans or through Medi-Cal, to take advantage of preventative services that could then minimize our risk, also prevent us from, succumbing to or at least developing more chronic health conditions. So that's important. That's an important note to I think take away, that we do have some power and control over our health and well-being, and it's important for us, if we do have healthcare or not, to really exercise that that opportunity or take advantage of that opportunity. So you talked about. Oh, go ahead.
One quick thing, which is,
Sure.
I just want to really underscore your point, which is coverage is, it's necessary but not sufficient, right? You need the coverage and then you need the care, but it is foundational. And there are studies actually showing that increased coverage is linked to reduced mortality. When you look at particularly Medicaid expansion, that's where most of the studies have been done. There's nothing to suggest that it wouldn't be true for marketplace as well. So I just want to underscore what you're saying, which is the first step is to get covered. But then once you have coverage, use your coverage.
Right. And for those of you out in the audience who may have gotten enrolled through CBHN or even through a Cover California service representative, if you have any questions about, especially if you're newly enrolled in healthcare coverage, if you have any questions about what services you now have access to and are available to you through your healthcare plan, you can either call our office and we'll connect you to a certified enrollment counselor, or you can also contact the Cover California service to get your questions answered. There's always someone available to assist you in making sure that you're able to utilize and maximize the services and resources that you have available to you. So I want to go back to the health equity initiative that you talked about earlier. Can you tell us more about, like, so what if Cover California got everyone in Cover California, healthcare plan or is insured? Then, what's next? Like, what happens next after we reach that utopia, I guess?
Yeah, yeah. No, I think it builds on each other, right? Let's get everyone covered. Let's get everyone connected to care. And we've been leaning on our health plans, for example, to really promote primary care and making sure that people who are enrolled know the value of primary care and are actively choosing a primary care provider rather than just being handed a card and an assignment, so that they're more activated and engaged. And then I think it is about holding health plans and their contracted provider networks accountable for the quality of care. And within quality, we say at Covered California, equity is quality, right? So every component of quality, we look at through an equity lens and saying, it's not just the top line number, but how are all the diverse communities within that number doing? Because we know that disparities are prevalent and deep. So I think between our outreach and enrollment efforts, particularly with ARP subsidies in place, and then our healthcare accountability quality transformation initiative, we're hoping those two pieces come together to really, in 3 to 5 years, create measurable changes in health status.
Okay. So I want to take a break for just a minute. I've asked you a lot of questions and I want to give the audience an opportunity to ask some questions. And just a reminder, please put your questions in the Q&A box so that we can keep track of all the questions. And so there is one actually from the chat box that says, why does DPSS go into our Cover California accounts and make changes knowing that the adult families do not qualify for Medi-Cal due to income? Knowing this, they now have coverage in limbo and have a difficult time calling DPSS. This is very frustrating as an enroller. I have a difficult time explaining this to clients. So I don't know if you're able to address that issue, Dr. Chen, or if you can direct this person to a resource at Cover California who may be able to help.
See. I will need to phone a friend on this one. I'm not deeply enmeshed in our enrollment side, but I will definitely, if Coretta, you can email me, and I'll just give you my email, which is alice.chen@coveredca.gov. Actually, let me just write that. I'll put it in the chat. I'm happy to connect you to the right person.
Okay. Yeah, and it looks like, what time is the media event? So what time is the media event tomorrow? I guess that was not for the general public, but for us. I believe it's at 10 a.m., right? Tomorrow?
10 a.m. Yes, and it'll 10 a.m. Welcome everyone on this call to join us. We're going to be sharing our latest enrollment data, which is really exciting, both top line and specific to some of our communities of color. And then we're going to have Rhonda as a featured guest speaker, as well as Dolores Huerta and a few very esteemed physician leaders who are focused on disparities here in California.
Right. And that information is posted on the Facebook page or on social media for Cover California?
Yes.
I think, yes. Okay, so the link to join would be either Facebook, Instagram, or Twitter for Cover California. So another question is, with the greater demand for mental health needs, I am interested in learning how Cover California is working with and paying private practice therapists to increase access for Medi-Cal members? Any sense of that?
We don't have any purview over Medi-Cal, but what I will say is that we are leaning into behavioral health. We've expanded, our health plans have expanded the networks of mental health and substance use providers by about almost 30% over the last few years. We are also working with Medi-Cal and CalPERS on a joint behavioral health initiative, trying to better understand what the collective barriers for Californians in our 3 programs are to accessing care. And that includes issues around network adequacy. And how do we measure network adequacy? What are the quality measures that we should be holding our health plans and our providers accountable to?
Yeah, I know that one of the challenges, at least that I've heard, especially for Medi-Cal recipients, is I guess it's getting providers to be qualified to provide services through Medi-Cal coverage, and then you layer onto that finding a culturally appropriate or therapist or someone that a Medi-Cal recipient is seeking, who they can, I guess, feel like they can trust and connect with, that they can relate to. So I don't know if there's any information that you have about that, or any potential changes that may be on the forefront in that regard.
Yeah, I think one of the complications in Medi-Cal that Medi-Cal is actively working on is this historical division between what they call the SMI system of care, severe mental illness, which is run through the counties, and then mild to moderate, which runs through the health plans. And so there is this challenge, first and foremost, when you're trying to get to a provider, of even knowing what door to go through. They're trying to integrate all that so that there is no wrong door for a Medi-Cal enrollee, and so it's more seamless care. I think in terms of the access to culturally concordant, racially concordant members, I think that is a big focus area. We are limited by workforce. Honestly, the pipeline issues are really dire, and I know that Medi-Cal is leaning into that as well on a couple of fronts, both looking to other state departments, trying to enhance pipelines for traditional behavioral health providers, and also looking at non-traditional behavioral health providers like community health workers and peer navigators and things like that, to really both expand the scope and to leverage telehealth. I think there's not going to be an easy solution in the short term. And we at Covered California are looking at some of those same things, looking at how do we make sure that the provider networks we have meet the cultural and linguistic needs of our enrollees.
Great. So another question is, there's new money for the ACA and Covered California and the Build Back Better bill, but person wants to know what happened if that bill is never really passed in the way that it was intended to be.
That is the question in front of us right now. So as many of you know, American Rescue Plan really augmented the federal subsidies and made coverage much more affordable for Californians and for Americans across the country. Those ARP subsidies are set to expire at the end of this year. Build Back Better would extend them for another 3 years through 2025, as well as have additional funding for cost sharing reductions. I think it's two questions. One is, do the ARP subsidies continue? If they don't, that will really send us back to the drawing table as a state. And what it'll really call the question of is, even though we have a budget surplus, it is limited. And what are the priorities? Right now, there's a really ambitious proposal to make Medi-Cal really truly universal, right? We as a state have been really on the forefront of expanding Medi-Cal to undocumented below the age of 18, and then below the age of 26, and now over the age of 50. And this latest proposal will just fill in the gap so that we truly have a universal safety net system for those who are low income. If the ARP subsidies go, then the question is, okay, we have this money. How much is left over after we do that to fill in the gap? It's a big gap. The ARP subsidies are about $1.6 billion. And what I would say is one of the reasons, one of the policy innovations around augmenting those subsidies came from California. Before ARP, California had state subsidies on top of the federal subsidies to try to make things more affordable. But we don't have an extra $1.6 billion in our back pocket. So that is a really important question. It's something that we are actively tracking. And, you know, I don't want to, I don't know, my Jamaican friends say goat mouth anything, but I would say that there is bipartisan support. And so the hope is that at minimum, the ARP subsidies would continue, even if Build Back Better doesn't pass.
So, you know, one of the things that Cover California, the California Black Health Network does is, you know, advocacy, right? So we advocate to do our part to help advance health equity. But I'm wondering if, you know, the people listening today, if there's something that they can do in the way of advocating for support and to move this legislation forward. Is there anything that we as citizens can do to help make progress towards getting the Build Back Better bill passed, in your opinion?
Yeah, well, as a state agency, we don't do advocacy. We're prohibited from doing any political advocacy. But what I would say is to anybody, any citizen of the United States, is that we are a democracy, and you should call your elected officials on whatever issue it is that's important to you, and make your voice known. I do think that in this particular case, again, it does have bipartisan support. There is discussion on a policy side of taking out those components and passing it through some other venue. So it would be useful to keep tracking it and to weigh in for those of your members and audience who are in support.
Okay, great. So it's not necessarily a question, but so please expound on how to hold, I guess, entities which are health insurers accountable when patients don't feel heard or they feel intimidated or by fear or of ignorance and or retaliation from speaking up. So I guess maybe this is kind of speaking to implicit bias a little bit, and some things that people experience when they're seeking healthcare.
Yeah. You know, I would say a couple things. I'd say, one, this underscores the importance of having, when you choose a health plan, making sure that the network that's available to you is one where you have providers who you'd want to go to. I think the other piece for us at Covered California is one key principle for us is ensuring choice for consumers, because honestly, there is a information and power asymmetry in the healthcare system. And I think not everyone does feel comfortable. I think and let me just back up. If you do feel like you have not been treated well, correctly, you know, with respect, the first line is always to let pretty much all health care organizations, whether it's a provider organization, a hospital, or a health plan, has a customer service component where you can call or go online and file a grievance. And I think it is important to make sure your voice is heard. And when it's appropriate, you take your business elsewhere and you find another provider or organization that can meet you where you need to be.
Great. So another question is, will Cover California and Medi-Cal ever use a common database so that Cover California Help Desk can go into a Medi-Cal account and make the necessary changes that are required?
Again, this is a phone a friend question. I know we do use a common database for eligibility for CalHERS. I also know there is some protectiveness in terms of each group owning their data. So if there's a specific example of that would be helpful, feel free to email me and I can figure out if there's something in the works or if there's something that actually may be possible already.
Yeah, I think this next question may also qualify for that. So someone wants to know what is available for the elderly who have a share cost of $1,000 and are on a fixed income.
So if by elderly, it's someone over the age of 65 who's eligible for Medicare, then Covered California, unfortunately, is not an option, because the way the program is set up is that if you are eligible for Medi-Cal or Medicare or affordable, and there's some, numerical parameters on affordable employer-based insurance, you are not eligible for Covered California.
Okay, great. So we did have one question in the chat box, but I think we kind of answered it because it's related to the process of holding entities accountable. So it's when patients and stakeholders are met with barriers to addressing issues, what's the next step? So you recommended calling and making whoever is responsible for basically customer service or patient service and experience at that institution to let your experience be known. But I think there's also a state agency that also handles complaints. Can you share information about that as well?
Absolutely. So if it has to do with the health plan, DMHC has a I'm forgetting the name of it, but it is a consumer helpline, and they are very helpful in terms of adjudicating different issues with health plans in particular.
Yeah, and a question, doesn't the Department of Managed Care work on complaints?
I'm sorry, DMHC is Department of Managed Healthcare.
Okay.
I should learn not to speak in acronyms.
Acronyms, yes, that's no worries. So there are a lot of great questions that have come in the chat in the Q&A box. I also want to ask the audience to make some comments or provide some suggestions for what you believe Covered California can do to help better serve the Black community and have more of a focus on the Black community, or what are some of the needs that you're seeing, especially some of the enrollment counselors that can help you and support you when you're doing your outreach and enrollment, or what are you hearing from the community that Covered California could do? This is the opportunity when we talk about continuous improvement, could do better. And I can start by saying, from a marketing perspective, I think having the right kind of imagery that would be helpful in producing collateral materials that we can share at events and as part of doing the outreach, and building awareness and communication around open enrollment and what options are available for folks. We at least in my experience, we found the options for images that we could use and repurpose very limited. So maybe having more of a toolkit, more diversity in the toolkit that is available for navigators and enrollers.
That's a great suggestion. Thank you.
Yeah, I don't know if any of the CECs have any other suggestions. I'm not quite sure from a Covered California communication standpoint what, direct to consumer, so to speak, initiatives or activities are underway that are specifically targeted for the Black community. I don't know if Angie, I think Angie's on. I don't know if she wants to weigh in. This might, on that question a little bit. If you want to, I guess we would have to unmute her. But a question in the meantime is, does Covered California do any outreach directly to Black churches and or NAACP chapters?
I will wait to see if Angie gets unmuted. I will say, to my knowledge, we are direct to consumer outreach is primarily through media. So paid advertisement, earned media. We rely typically, I think, on our CBOs like a Black Health Network to then be the interface with individual churches and chapters. But I see Angie is off mute and can correct me if I'm wrong.
Yes, I am. Thank you for that great question. Yes, through our outreach and sales division, and I know that enrollers, the certified enrollers for the California Black Health Network can also speak to this as well, but we do have targeted outreach toward the Black and African American community. We have done many activities with the faith-based groups and faith-based leaders in the past. We continue to do so. Matter of fact, one of your enrollers, Coretta Rolfe, had a Cover California booth at the Fame Church in Los Angeles on Martin Luther King birthday yesterday. And so we try to continually go into communities of color, particularly the Black community has been impacted disproportionately by the COVID-19 pandemic. So we are working with groups like the California Black Health Network and other navigators throughout the state, as well as our agent population, some of whom are NAACP members, and we have done events and activities with them in the past, and we'll continue to advocate to do more of these type of activities, because it's so very important that we have a public face in Black communities and other communities of color throughout the state. So I hope that answers your question. If you want me to elaborate a bit more, I can.
Sure, if there's more information you can share, that would be great.
Well, the one thing that I would encourage our Cover California partners and other people in the public, if you do have ideas, if you do have opportunities where Cover California can come into your communities, your community organizations, and perhaps speak to your group or have enrollment fairs with your organizations or in your respective communities, please reach out to us. I will leave my my personal contact information in the chat box, and you can reach out to me directly, and I will forward the information to the appropriate person, because as an African American myself, I am passionate about this, and I will do whatever I can to advocate for these type of opportunities now and in the future.
Yeah, and I can attest to that. So thank you, Angie.
Okay.
So
Magda,
yeah.
do you mind,
yes.
just based on Angie's comments, thank you so much for jumping in there, made my wheels turn. I would love to hear from the participants, who are the residual uninsured in the Black community in California? You know, what are the best venues? Who are you seeing in your family, friend networks who don't yet have insurance? What are the things that we need to be doing to reach them?
Yeah, so if there are any thoughts about that, like in this moment, that would be great. If there's nothing that is coming to mind, you can always get in touch with Angie and share that information with her after the webinar. And let's see, Angie, is your contact in the chat yet?
Yes, it's coming, but I did want to say one area that's been hard to reach, and Rhonda, you spoke of this in some of your comments, is the Black immigrant population. And you know, we have thousands upon thousands of Black immigrants in California, from various countries, various ethnicities, and various religions. And we're trying to do more to reach those populations.
Right. And I think one of the important things there too is that if any of the individuals that are part of that population are undocumented, they could still get access to healthcare coverage. So
Correct.
that is, and I think California is the only state that actually offers that through its Affordable Care Act program. So that's, oh, go ahead. No.
And just to make sure that folks understand, that's for Medi-Cal. So if you have an income of below 138% federal poverty level, we're not there yet. But the hope is right now, the federal government actually does not allow anyone who's undocumented to get coverage through the exchanges.
Okay.
Medi-Cal, the feds won't put a cent into it, but we as a state have decided this is the right thing to do. We're leaning in and we're doing universal coverage. That would be a logical place for our state to go next. We're not there yet.
Okay. Okay, great. And I see Angie put her contact information in the chat box. So thank you very much for that. And then just a couple questions before we wrap up today. So what can organizations like the California Black Health Network do to help support Cover California's Health Equity Initiative, what your focus is going forward, and having a greater impact in terms of improving outcomes?
Yeah. Well, I think first, by being the partner you are and really leaning into getting the residual uninsured covered. Secondly, really figuring out how we make sure that communities know that that there are multiple coverage options, so that if they, for example, make a little bit too much to be in Medi-Cal, that they know that they're seamlessly transitioned into Covered California and vice versa. Like if you're in Covered California, how do we make sure that people have kind of continuous coverage? And then I think the other piece is, I'm hopeful as we move forward with our quality transformation initiative that our health plan partners will also be turning to organizations like yours to communicate with the community, or to help them better understand how to engage effectively with the communities they're trying to reach and improve outcomes for. So I think, again, our four major areas are blood pressure, diabetes, colorectal cancer screening, and immunizations. I could imagine partnering on public education campaigns around those issues and better understanding, what are the barriers, the misconceptions, the decision points that need to be addressed in order to get better uptake and control in those areas.
Okay. And then one last question for you, Dr. Chen, what do you want to, or what do you envision as leaving as your legacy in your role? I know you've been in this role for a little less than 2 years now or something in that vicinity. A year. Okay. Yeah, but what do you envision, or what do you want to leave as your legacy in your role as Chief Medical Officer at Cover California?
Yeah, that's a great question, Rhonda. I think that it goes back to what I mentioned before, which is I would love to see, I don't know if I'll be gone by then, but in 3 to 5 years, that we have measurable improvements in community health, and in particular for our most vulnerable communities. I think Angie mentioned, COVID has been devastating for Black and Latinx communities. I think most people on this call probably know that as a country, we've lost at this point 1.5 years of life expectancy, but for Black and Latinx communities, it's double that. I mean, that is astounding. 3 years over the course of, a 2-year pandemic. And related to that, many of the conditions that I was talking about have also taken a hit in terms of blood pressure control and diabetes control and immunizations for kids. And so really leaning in and hoping that in 3 to 5 years, not only have we caught up to where we were before COVID, but that we've actually closed some of those gaps.
We have a lot of work to do, right?
I know. We have a lot of work to do.
We have a lot of work to do.
Yes.
Yes, that is great. Okay, so thank you so much, Dr. Chen, for your time today and for sharing the information about what's happening at Cover California and for being a good partner. I've enjoyed getting to know you and working with you, and I look forward to how 2022 evolves and we move forward together in our partnership. I want to wrap it up and just share a few final things. So Gladys, can you share a couple of slides? Yeah, so just a reminder that open enrollment ends January 31st. You can contact CBHN at getcovered@cbhn.info or call our office at 916-333-0613, and we will connect you to a certified enroller who can work one-on-one with you in your local community and in your coverage area. So last slide is, please join us, become part of the campaign for Black health equity. It's our initiative to really advance health equity and see measurable differences in health disparities reduction. And then also you can connect with us on social media. It's really easy. It's at Your CBHN for all of our social media platforms. And we're on LinkedIn as California Black Health Network. So again, thank you all for attending today, and have a great Tuesday. Take care. Bye-bye. Happy New Year too. Thank you.